Ever since I was a child, I've been obsessed with fairness. This is a lecture about fairness, specifically fair trials, a process where everyone involved gets a fair chance. My most memorable school assignment was an essay entitled "Did Jesus Receive a Fair Trial?" As a child obsessed with fairness, I desperately wanted to know the answer. How could a man who was so good and so kind end up being crucified by the people whose lives he was trying to save? It just didn't seem fair. Now, this was 1986. There was no internet, so answering this question meant consulting a textbook or an expert. I couldn't find the answer in a textbook, and I knew no experts, so I asked my mum and dad. Now, they didn't know, but they did remind me that our neighbour's son was a lawyer. So I knocked on their door, but he wasn't in. Our neighbour kindly passed him a message, and a few days later I received a phone call from an Oxford University professor of theology. "I hear you have a question," he said. "Yes, I do. Did Jesus receive a fair trial?" Now, he chuckled and told me this was a difficult question, one he'd normally set his university students. He asked me how old I was, and I replied 12. Now, to understand if Jesus received a fair trial in Roman times, he told me, you must first know what a fair trial looks like today in 1986. So I caught the train to St. Paul's, my mum came with me, and we watched a trial at the Old Bailey. The young man in the dock stood accused of GBH, that's grievous bodily harm, and I confess I took one look at him and decided he must have been guilty. To me, he looked like a guy who would beat someone up. Now, would it have made a difference if the defendant had been a beautiful woman? Remember, I was a 12-year-old boy. Well, the answer is probably yes. Studies show that justice really is blind, and jurors are more likely to side with attractive than unattractive individuals. Now, the individual on trial, Librela, is undoubtedly beautiful. Any drug capable of improving quality and quantity of life is beautiful. Now, I, like you, embrace that. I started my career in veterinary anesthesia, a discipline obsessed with pain control, and I've spent the past 21 years working in specialist orthopedic practice, doing my very best to alleviate pain in dogs and cats. I'm not here to share my personal opinion on Librela. I'll present a series of facts, and I'll present those facts from the perspective of an expert with no conflict of interest. Some of the facts were collected by me, but most come from other specialists who also have no conflict of interest. Here's the first. Andy Moores is one of the most respected experts in the field. He's been a specialist for over 20 years and has a worldwide reputation for excellence. And he's published over 50 book chapters and papers, including this one comparing CT findings to arthroscopic pathology in dogs with elbow dysplasia. Andy Moores is the expert on this subject. At the end of 2020, Andy acquired this CT scan from a 7-year-old Labrador Retriever with elbow dysplasia that was too subtle to show up on a volume reconstructed CT scan. Here's the CT scan of the elbows of the same dog after 23 Librela injections. Andy filed a report to the VMD in answer to the question, "Do you think this product contributed to the adverse signs observed?" And he said yes. His description of the reaction was rapidly progressive osteoarthritis. Specifically, he said this dog has shown much more rapid progression of elbow osteoarthritis than is typical, and Librela treatment is considered a possible cause of this. Now, reports are always shared with the drug's manufacturer, in this case Zoetis. Andy said the problem was serious, they said it wasn't. They also changed the outcome from ongoing to recovered or resolving. What happened here? Why did this dog have subtle elbow pathology aged 7, then extremely abnormal elbows aged 9? A world-renowned authority on elbow arthritis flagged a serious issue to a national regulator. The drug's manufacturer responded by filing a radically different report. If I were in your shoes, I'd want to know how this happened. That's why I'm here to tell you. So let's start at the beginning. In 2008, a year after Purdue Pharma admitted misrepresenting OxyContin, people were rightly afraid of oral opioids. But around a third of people suffer from chronic pain, and physicians were desperate for a new class of painkillers. That class, anti-aNGF monoclonal antibodies, arrived in 2008, and the first large clinical trial involving 450 patients was published in 2010. The results were promising, so human clinical trials were expanded to include over 11,000 patients. And that's when things started to unravel. Around 3% of treated people developed severe acceleration of their osteoarthritis, a condition termed rapidly progressive osteoarthritis, or RPOA. So early anti-NGF drug trials were performed at the height of the opioid crisis, whose handling by the FDA had been heavily criticized. This was mainstream news, so when the FDA was tasked with overseeing anti-NGF drug development, the world was watching. The FDA put all non-cancer clinical trials on hold, then met in 2012 to discuss releasing that hold. Here's a quote from the meeting transcript from a Harvard University professor who said one of the problems is the quality of the data, because preclinical trials did not indicate that we needed to have concerns about rapidly progressive osteoarthritis. In other words, large-scale clinical trials were vital because early laboratory animal studies failed to identify the problem. He said we're struggling because we don't know how rapidly their native disease was progressing prior to the study, and we're trying to speculate about it after the fact. We're being asked to render a judgment about this class of medications in an environment where we're all struggling with the inadequacy of the data, and he wasn't the only concerned expert. Another FDA panelist said whatever we call them, and whatever the underlying process is, these events are severe, and they seem to be occurring in relationship to exposure to these agents. When he says these agents, he's talking about 3 drugs, all from the same class, whose severe side effects were self-reported by 3 different manufacturers. RPOA has several definitions, most of which can't be applied to 4-legged animals, but one practical definition from the 2012 FDA meeting was degenerative joint pathology falling well outside the natural history of osteoarthritis. A journey to the truth must always start by asking why. So why would NGF suppression accelerate osteoarthritis? Because, I quote, nerve growth factor receptor plays an essential role in the remodeling and repair of osteoarthritic joints. In other words, this is a predictable biological effect. So RPOA could be defined as an expected consequence of suppressing a neurotrophin with a crucial role in cartilage and bone tissue maintenance and repair. The FDA took decisive action, voting 21-0 that RPOA was a side effect of this drug class and mandating a compulsory risk evaluation and mitigation strategy for all subsequent trials. Why? To limit the potential risks to patients. To be enrolled, patients had to be intolerant to nonsteroidals and paracetamol and willing to accept around twice the risk of ultimately needing a total joint replacement. After 18,000 patients were screened and 50,000 radiographs analysed by 250 experts, the FDA concluded that the benefits did not outweigh the risks. Was there an unmet need for a new class of painkiller? Yes. Was this drug class the answer to that unmet need? No. In another FDA meeting to decide the fate of the most promising human anti-NGF drug, tanezumab, the FDA chairperson said, I quote, "It is counterintuitive to use a drug for osteoarthritis that actually makes osteoarthritis worse." How does the approach of Zoetis, the only veterinary anti-NGF drug manufacturer, compare? Well, here's their preclinical study in healthy pain-free beagles. This is the only published study which tested dogs for accelerated OA, specifically x-rays of the knees, hips, shoulders and elbows of healthy beagles were taken before treatment and 6 months after starting treatment. Zoetis reported radiographs of only 5 dogs receiving the recommended dose. Remember, in the equivalent human trials, preclinical studies did not indicate that they needed to have concerns about rapidly progressive osteoarthritis, but history tells us that they did need to have concerns. In the veterinary field trials, only 89 dogs received more than 3 doses of Librela, and there was no radiographic screening for accelerated joint degeneration. Unlike the manufacturers of human drugs who self-reported accelerated joint destruction, Zoetis could not self-report because they did not perform the necessary tests. Absence of evidence is defined as lacking proof of something. But from Zoetis' perspective, it seems absence of evidence should be interpreted as evidence of absence. Importantly, experts without financial ties to Zoetis disagree. Simply because something hasn't been found does not mean it's not there. My colleagues and I asked the obvious question: do Zoetis believe it's appropriate to make conclusions about joint safety based on 6 months follow-up of 5 healthy dogs? Zoetis responded, telling us that they had already done enough. Apparently dogs, unlike humans, didn't need a REMS program. Zoetis cited a 2011 study as evidence that anti-NGF drugs do not accelerate arthritis in monkeys. But the cited researchers in that study did not perform histopathological analysis of joints. Zoetis' response was authored by senior members of their global pharmacovigilance team and a senior pathologist. They're responsible for the safety of millions of dogs, and it's their job to know the relevant literature and present it accurately to the public. They didn't do their job. They also said this, I quote, "The Zoetis pharmacological database was most recently queried in the spring of 2024 for cases containing the terms RPOA, rapid progress, fracture, radiograph, bone and joint disorder, joint pain and arthritis. The dataset did not identify any cases of an RPOA-like condition of degenerative joint disease. Keep this in mind because it's important." I have nothing to gain from people dispensing more or less Librela, so why am I here talking to you? Well, I'm not here because I want to be, I'm here because I'm a published expert in radiographic interpretation of canine osteoarthritis, and one of my residency supervisors, Professor David Bennett, is an expert in the other form of naturally occurring arthritis, IMPA. Erosive IMPA is very rare, constituting less than 1% of all IMPA cases. Between 1971 and 2021, there were only 14 reported cases of erosive IMPA. Even if we include cases described as rheumatoid or rheumatoid-like, a total of only 57 cases were reported over 50 years. I'm also an expert in insufficiency fractures. I've published on why it happens and how it's treated. But most importantly, I've worked in general practice trying to achieve the impossible, helping 20, 30 or even 40 people per day make the best choice, knowing there's no such thing as a best choice, only an informed one. The index case who first triggered my concern was Stanley, a 1-year, 4-month-old Labrador. Images A and B show CT slices taken 6 months before starting Librela. The changes are typical of elbow dysplasia, but we can't see any sign of a stress fracture known as a humeral intracondylar fissure, or HIF. These radiographs were taken after 6 monthly Librela injections. There's an obvious poorly healed humeral condylar fracture with proliferative new bone formation, which we don't typically see in dogs with these injuries. We also rarely see them in Labradors, and Stanley was my first. These radiographs were taken 3 months after reconstructive surgery. The fracture healed, but articular bone resorption progressed. Tragically, this resulted in intractable pain and Stanley was euthanized. Stanley is one of 7 cases submitted by a board-certified specialist before Zoetis reviewed their database, where the attending specialist filed a report using the specific term rapidly progressive osteoarthritis. Zoetis filed a report for septic arthritis, but they knew we'd ruled out septic arthritis with serial joint fluid analyses and necropsy. We sent them the necropsy report, which stated, I quote, "The histological features are similar to those described within the included article. That included article described human RPOA." Stanley was the first Labrador I'd seen with a humeral condylar fracture, but soon after a colleague shared another, a 1.5-year-old with similar features. Pre-treatment CT showed no humeral intracondylar fissure. After 6 monthly Librela injections, another elbow fracture with atypical periosteal reaction. This dog also had surgery, and a surgical biopsy excluded infection, IMPA and cancer. Similar cases kept coming without a formal request. In other words, I was not recruiting cases. This dog had unremarkable pre-treatment x-rays and fractured both elbows after 5 Librela injections. If you read our paper, you'll see case numbers. To readers, this is Case 15, an 8-year-old English Bull Terrier. To me and to his family, Case 15 is Harry. Harry had Librela to treat mild elbow dysplasia. He had clinically normal hocks before treatment and developed severe hock joint swelling within 3 weeks of his first dose. X-rays taken after 2 Librela injections show moderate arthrosis in both hocks, which progressed rapidly, culminating in end-stage arthritis and left-sided joint dislocation. Here's a 6-year-old Staffordshire Bull Terrier with no history of trauma and unremarkable pre-Librela CT scans. This dog developed severe pathology, including an elbow joint fracture after 30 Librela injections. This was reported by the attending specialist as RPOA, but Zoetis filed their report with a diagnosis of osteosarcoma. If you were in my shoes, what would you have done? Would you have blown the whistle on Zoetis, knowing things rarely go well for whistleblowers? Did I want to do it? No. But did I have to do it? Like it or not, the answer was yes. Fortunately, there was no need to start from scratch. The FDA had already provided a roadmap with their 2012 adjudication of human anti-aNGF drugs, so we modelled our independent adjudication on theirs. I assembled a team of 18 independent experts, including a leading expert in human neuro-osteoarthropathy, a cancer researcher with 30 years' experience developing monoclonals, 2 diagnostic imaging specialists, 2 specialists in veterinary anesthesia, and multiple experts in veterinary orthopedic surgery. We tested a hypothesis that musculoskeletal adverse event reports would surge and taper following the launch of new drugs, by analysing data from the Vigilance database since its 2004 inception. In other words, 20 years of data. With the notable exception of Librela, there were no surges, so we rejected this hypothesis. In fact, there was a 9-fold difference in the incidence of serious adverse events, including ligament injury, polyarthritis, fracture, cancer, and joint infection when Librela-treated dogs were compared to the combined total of dogs treated with 6 comparator drugs. Here's a question. Librela is used to treat osteoarthritis. Would you report arthritis, the condition you're treating, as an adverse reaction to Librela? I'd choose D. It's highly unlikely. Now keep this in mind because it's relevant. You don't choose the diagnostic terms on the final adverse event report. It's the drug manufacturer's job to select terms from VEDRA, the Veterinary Dictionary for Drug Regulatory Activities. 2/3 of the diagnostic terms chosen by Zoetis were arthritis or associated clinical signs, for example, lameness, joint pain, and difficulty climbing stairs. Of these, Zoetis filed 8 out of 10 reports as not serious. The remaining 1/3 included ligament injuries, joint collapse, polyarthritis, bone cancer, and fractures. Among these, Zoetis filed around half as not serious, including most ligament ruptures, joint or bone infections, and even 1/3 of fractures. Notably, Zoetis reported several dogs diagnosed with bone cancer as recovered or resolving. Here's another example, a 5.5-year-old Australian Shepherd dog who had stable stifles, no history of trauma, and normal X-rays before starting Librela. After 7 Librela injections, he sustained complete derangement of both stifles with bilateral fibular fractures. Zoetis filed their report stating that these effects were not serious. We define translation errors as clinically relevant discrepancies between the reports submitted by attending vets and corresponding reports filed by Zoetis, and we found them in 9 of 19 cases. Here's the problem. Normally, when we file a report to an expert, they reply to us. Say you sent a blood sample from a dog and they diagnosed feline leukemia. You could call them and discuss their error. There is no such feedback loop with Vigilance. Cross-checking reports is feasible but difficult, and people aren't doing it. There are different definitions of serious. According to the EMA, serious includes adverse events which result in persistent or significant disability. If you're reporting, please be specific. If you believe it's serious, explain why. While we were working on our analysis, so too were the FDA. Like us, they identified a very high rate of worrying adverse events in dogs receiving Librela. Specifically, the FDA identified 22 statistically significant safety signals, including seizures, impaired consciousness, bone cancer, and collapse. They said, I quote, that owners should be advised of the adverse reactions that may occur following administration of Librela. Here's a question. Why didn't the FDA chairperson say it's counterintuitive to use a drug for osteoarthritis that makes osteoarthritis worse in a small minority? I'll answer this question by comparing Librela to the best available oral painkillers, non-steroidal anti-inflammatory drugs. In this 2025 study from Zoetis, the authors highlighted a problem with non-steroidals. They can have limited efficacy and can cause significant adverse events. Quite right. But this statement also applies to Librela. We know from this study, also from Zoetis, that on average, Librela and the non-steroidal meloxicam are equally effective. But there will always be individual variation, and extreme examples draw our attention. Dogs for which Librela seems to do nothing, and dogs who behave like puppies again. While we focus more on them, we focus less on the majority. What about risk? Specifically, how does Librela compare to non-steroidals? Well, we have this recent point of comparison published in 2025 after the FDA identified Librela's 22 safety signals. So we have a choice. Take the FDA's word for it, or take Zoetis' word for it. Taking Zoetis' word for it means we must act as if pharmaceutical companies don't publish studies designed to flatter their products compared to competitors' products. Taking the FDA's word for it means looking at data collected before they wrote their open letter telling us to inform caregivers of the high risks of adverse events in dogs receiving Librela. This 2015 study assessed adverse event reports to non-steroidal anti-inflammatory drugs. There were 91 reports of vomiting per 1 million doses and 40 reports of diarrhea in dogs receiving the non-steroidal carprofen. In other words, vomiting and diarrhea are seemingly very rare, occurring in less than 1 in 10,000 doses. Zoetis is constantly comparing Librela's adverse event reports to its sales figures. Would you say this comparison offers a meaningful insight? Would you tell caregivers there's a less than 1 in 10,000 chance that carprofen will make their dog vomit or have diarrhea? Or would you say this comparison is seriously misleading? We initially intended to publish only a case series of dogs with accelerated arthritis, dogs who we didn't seek out but who came to us organically. But we became worried that people might dismiss these cases as outliers, isolated events swamped by widespread positive experiences. Given Librela's popularity, this perspective would be understandable. But this argument is like assessing the risk of NSAID-induced gastrointestinal harm by comparing the incidence of perforating ulcers with NSAID sales figures. It should be glaringly obvious that we're ignoring a crucial fact. NSAIDs can induce subclinical harm which is undetectable without inconvenient tests like endoscopy. But crucially, unlike the gastrointestinal mucosa, which has excellent healing capacity, cartilage damage is largely irreversible. What would you do if your patient vomited whilst taking non-steroidals? Well, it's obvious you'd stop them. With non-steroidals, trial and error usually works well. Give the drug, see vomiting or diarrhea, stop the drug, patient recovers. Trial and error works poorly if the side effect is occult. If Librela is accelerating arthritis, what's the most likely side effect? Well, that's also obvious. Waning efficiency. If it was working well but stops working well, should you treat it like a non-steroidal and stop the drug? Or will you persevere, perhaps even increase the dose or add a non-steroidal, knowing that both actions are proven to increase the risk of RPOA in humans? So rapidly progressive osteoarthritis could also be defined as the most extreme repercussion of anti-aNGF suppression on joint health, unless, of course, evidence is produced to the contrary. To date, Zoetis' approach involved the 3 Ds: deny, downplay, and deflect blame. They have consistently denied RPOA in animals, claiming it's a uniquely human problem. And they're willing to deny the fact in the face of high-quality evidence submitted by attending veterinarians. We see this in their approach to Harry. Remember, Harry had massive hock joint swelling within 3 weeks of his first dose, so his problem involved joints that had been clinically normal. Harry's local vet contacted Zoetis and told them they trusted that Zoetis would provide an accurate report, and they were shocked to discover Zoetis filed a report for a not serious, swollen joint which was resolved or resolving. That local vet performed joint fluid analysis to rule out IMPA. They contacted me through a mutual friend. I contacted Megan Shaughnessy, an ACVS diplomat who published the largest case series of erosive IMPA. She suggested a second joint fluid analysis to prove the first wasn't a fluke, and the result was the same. Harry does not have IMPA. Zoetis refused to accept the facts. I quote, "The Zoetis Global Signal Detection Management Team have reviewed all the information that was provided. The results from tarsal imaging and diagnostics were potentially consistent with one of the variants of IMPA, except that the synovial fluid analysis did not indicate inflammation at the time of sampling. They refused to accept the gold standard test performed twice. This is a company who, I quote, carefully analyse pharmacovigilance data, including the types of dogs that are being affected, whilst keeping an open mind about potential adverse events. Does their response sound open-minded to you?" In response to last year's FDA report, Zoetis chose to downplay neurological side effects, including seizures, rapid cognitive decline, collapse, and ataxia. For example, they questioned veterinary professionals' ability to distinguish ataxia from weakness. In other words, the same people who misinterpreted the study on anti-NGF drugs in monkeys is questioning your competence. Why? To defend Librela against the FDA's finding of a significantly increased risk of ataxia. Fortunately, your ability to recognize an epileptic seizure has not been questioned, epileptic seizures being 13 times more prevalent in dogs taking Librela compared to dogs taking other OA medications. How else is blame being redirected away from Librela? Well, there are two clear answers. The first is from Zoetis, who responded to the FDA's finding of 22 safety signals by arguing that Librela is a victim of over-reporting. But 9 out of 10 cases were reported by a vet or other healthcare professional. In other words, according to Zoetis, you're to blame because your professional behaviour is influenced by social media. Now, it's worth noting that the FDA found no evidence that your reports don't describe genuine adverse events to Librela. The second deflection of blame is a forgivable misunderstanding by lay people of osteoarthritis pathogenesis. I'll illustrate with a story. A close friend is a passionate runner who was diagnosed with knee arthritis. She was heartbroken about having to quit running. "Is it too painful?" I asked. It's not that, it's that I don't want to make the arthritis worse. But is that true? Does running genuinely accelerate arthritis? Before I let my friend quit the sport she loves, I felt she deserved to make an evidence-based choice. So I reviewed the literature with an open mind. I expected to find that running accelerated osteoarthritis, but I had no idea of the magnitude of the effect. The first paper I found involved 10 novice marathon runners. They had quantitative MRI before and after their marathon, and the study concluded that running did not lead to clinically relevant cartilage loss. But that's just one marathon, and the study participants had normal knees before the event. This systematic review included 14 comparisons of cartilage health from 9 studies. They found running did not seem to be harmful for articular cartilage in people with pre-existing knee osteoarthritis. Another systematic review included 43 articles with none rated as low quality. They concluded that running does not lead to the formation of new lesions in people with pre-existing OA. This study showed that daily treadmill exercise prevents cartilage fibrillation. In other words, running improves cartilage health. Here's an image from the limited exercise control group, and here's one from the treadmill runners. This lack of accelerated joint destruction shouldn't surprise us. Humans and dogs existed for hundreds of thousands of years, and most of our existence involved running after our food. We evolved biological systems to protect us from joint breakdown. Put simply, when we run, we release anti-inflammatory chemicals that protect our joints. So is it any surprise that overuse of joints due to loss of pain sensation is not thought to be the mechanism for human RPOA, a fact which is underscored by patients who suffered RPOA in previously normal shoulder joints? If that literature review doesn't convince you, perhaps this will. Case 19 in our study, a dog recovering from TPLO surgery. The images on the left were taken immediately after surgery and 8 weeks later. Here's what happened after 7 Librela injections. This dog was euthanized because of intractable pain. This dog did not have surgical site infection or septic arthritis. They were excluded by necropsy. This dog had post-mortem findings similar to those reported in human RPOA, and this dog was definitely not over-exercised. What now, you might ask? Well, I'll answer this final question by referring to this classic behavioural psychology study. Unsuspecting students found themselves in a smoke-filling room, either alone or, like you, with others. How long would it take them to report the smoke? When alone, 3/4 reported it within minutes, but when others were present, reporting dropped to 1 in 10. The FDA already told you there's something wrong, and I repeated their message of caution from a different perspective. Now it's time for you to decide, is speaking up someone else's job, or will you make it yours?